Let us begin with two patients. The first patient has an intraocular pressure of 30 millimeters of mercury. The conventional statistical reference range for intraocular pressure is approximately 10 to 21 millimeters of mercury. So this pressure is clearly elevated. However, this patient has a healthy looking optic nerve, no detectable glaucomatous damage, and a normal visual field. The second patient has an intraocular pressure of 15 millimeters of mercury, which is well within the conventional population range. However, this patient has characteristic glaucomatous optic nerve damage and corresponding visual field loss. Now think for a while and answer which patient has glaucoma. The answer is the second patient. If you chose the first patient only because the pressure was higher, that would be incorrect. The first patient has raised intraocular pressure, but there is no evidence of glaucomatous damage at present. This situation is called ocular hypertension. The second patient has glaucoma, however, because there is characteristic damage to the optic nerve with corresponding functional loss, even though the measured pressure is within the conventional range. And this is where glaucoma is commonly misunderstood, especially when we first begin learning it. We naturally associate glaucoma with raised eye pressure, and that association is understandable because intraocular pressure is important. It is one of the most important things we measure in glaucoma, and it is the major risk factor that we can probably modify. But pressure is only one part of the glaucoma story. To understand glaucoma properly, we need to understand what is happening to the optic nerve. A useful principle to remember is this: high intraocular pressure is neither necessary nor sufficient for the diagnosis of glaucoma. It is not necessary because glaucoma can occur even when untreated pressure measurements remain within the conventional population range. And it is not sufficient because an elevated pressure reading alone does not tell us that glaucomatous damage has already occurred. So, when we assess a patient, the real question is not simply what is the pressure. The most important question is this optic nerve being damaged by glaucoma? And that question will guide the rest of this lecture. We will first understand what glaucoma actually is. Then we will see how the optic nerve becomes vulnerable and damaged. And after that, where pressure fits into the larger picture. Let's start with the definition. Glaucoma is a group of optic neuropathies characterized by progressive loss of retinal ganglion cells and their axons. This is the definition you should carry forward. To understand it properly, let us quickly revisit the relevant anatomy. The retina contains several layers. Retinal ganglion cells are among the inner retinal neurons. Their cell bodies lie in the ganglion cell layer. Each retinal ganglion cell sends out an axon. These axons travel along the inner surface of the retina and together form the retinal nerve fiber layer. The nerve fiber layer then converges at the optic nerve head. From there, these fibers continue as the optic nerve. So, in simple terms, the pathway is retinal ganglion cell body, retinal ganglion cell axon, retinal nerve fiber layer, optic nerve head, and the optic nerve. Glaucoma basically affects this pathway. The essential problem in glaucoma is progressive injury to the retinal ganglion cell axons and eventually loss of the retinal ganglion cells themselves. A helpful way to understand glaucoma is to think of every optic nerve as having a certain degree of vulnerability. Some optic nerves can tolerate a particular intraocular pressure for many years without developing any damage. Another optic nerve may be more vulnerable and may develop glaucoma at the same pressure level or even at a lower pressure. This vulnerability is influenced by several interacting mechanisms. For examination purposes, it is useful to understand the major theories of glaucoma as the mechanical theory, the vascular theory, and the cellular or the neurodegenerative theory. Let us take them one by one. First is the mechanical theory. The axons of the retinal ganglion cells travel across the retina in the retinal nerve fiber layer and leave the eye through the optic nerve head. At the optic nerve head, these axons pass through a sieve-like connective tissue structure called the lamina cribrosa. The lamina cribrosa is important because it is the point at which the delicate retinal ganglion cell axons pass from the eye into the optic nerve. When the intraocular pressure is elevated or when the optic nerve head is specially susceptible to the pressure-related stress, the lamina cribrosa may become deformed and displaced posteriorly. As the lamina changes shape, the pores through which the axons pass may also become distorted. The axons can then be stretched, compressed, or bent, and this can disturb their normal function and impair axoplasmic transport. Axoplasmic transport is the system through which essential material moves between the retinal ganglion cell body and the brain. And when this transport is disrupted, the axon receives less support. Over time, the retinal ganglion cells become more likely to fail and die. A simple analogy is to imagine many delicate electric cables passing through a perforated support plate. If the support plate bends backwards and its holes becomes distorted, the cables running through it may become stretched, pinched, or damaged. In glaucoma, the retinal ganglion cell axons are like those cables, and the lamina cribrosa is like that support plate. So, the mechanical theory explains how pressure related stress can damage axons at the optic nerve head. Next is the vascular theory. The optic nerve head also needs a continuous and stable blood supply. Blood flow depends on adequate perfusion pressure and on the ability of local vessels to regulate blood flow according to the tissue needs. If the optic nerve head perfusion becomes low or unstable, the tissue may receive less oxygen and fewer nutrients. This may occur with reduced ocular perfusion pressure because of various reasons: impaired autoregulation, vascular dysregulation, or repeated fluctuations in blood flow. A simple analogy is an irrigation system supplying a field. A field may look normal for some time even if the water supply is reduced. But if the reduced flow continues or fluctuates repeatedly, the most vulnerable areas begin to suffer. Similarly, reduced or unstable perfusion may make the optic nerve head more susceptible to damage, especially when pressure related stress is also present. This vascular theory is actually applicable when we talk about the normal tension glaucoma, where the pressure is normal, yet the patient suffers from glaucomatous damage of the optic nerve. The third mechanism is the cellular theory or the neurodegenerative theory. The retinal ganglion cells are highly active neurons. They need a continuous supply of energy to maintain their normal functions. Much of this energy is produced by the mitochondria. Mechanical stress, reduced perfusion, age-related changes, and oxidative stress can all impair mitochondrial function. And once the mitochondria stops working efficiently, the cell produces less energy and may generate more reactive oxygen species. These reactive oxygen species can further damage the proteins, cell membranes, and DNA of the cell, and therefore the retinal ganglion cell now struggle to survive. This is known as the cellular or the neurodegenerative theory. In response to the dying retinal ganglion cells, there is also a glial or inflammatory response. The astrocytes, microglia, and the Muller cells normally support the retinal neurons and they help to maintain the local environment. In early injury to the ganglion cells, this response of proliferation of the glial cells is protective. But when the stress becomes persistent, prolonged glial activation can contribute to a harmful inflammatory environment. The same cells now bring cytokines, cause oxidative stress, disturb the glutamate handling and other mediators, and may further increase retinal ganglion cell injury. A useful analogy is an alarm system. Initially, the alarm alerts the support system and brings help to the injured area. The support system here is the inflammatory response and the glial tissue. But if the alarm remains switched on for too long, the response itself can become disruptive. In the same way, chronic glial activation may shift from support to additional injury, and these mechanisms basically interact with each other. Mechanical stress itself can cause or can alter local blood flow. Local blood flow, when disturbed, causes reduced perfusion, and that can worsen mitochondrial dysfunction. Mitochondrial, once is not functioning well, can increase the oxidative stress, and that chronic injury can activate glial and inflammatory pathways. The final common result is injury to the retinal ganglion cell axons and progressive loss of the retinal ganglion cells. As the axons are lost, the retinal nerve fiber layer also starts becoming thinner, and this we see in the form of the retinal nerve fiber layer defect. With further neural loss, characteristic optic nerve head changes also develop. This we will study when we talk about the optic nerve head changes in glaucoma. There's already a video on the channel. The link will be given in the description box. So the disease process we have discussed becomes clinically visible in two broad ways. There is a structural change that you see in the fundus and a functional change that you find in your investigations. Structural change occurs because the retinal ganglion cells are progressively lost, and this loss can affect the retinal nerve fiber layer and the optic nerve head. Functional change occurs because the retinal ganglion cells carry information from the retina to the brain, and when enough of these cells and axons are lost, visual function can be affected and corresponding visual field defects may become detectable. So, glaucoma has both structural as well as functional consequences. We already have foundational videos on optic nerve assessment, OCT, and visual fields. You can revisit those videos when we reach the detailed parts of the glaucoma module. For this lecture, keep one principle in mind. Structural and functional assessment are complementary. They are both closely related, but they do not always become abnormal at exactly the same stage of the disease. In some eyes, you might find structural evidence may be clearer first. In other eyes, functional loss may be more convincing first. And this is why one test alone is not enough to diagnose glaucoma. You might see just a large cup alone, and that is not glaucoma. You might sometimes see just an OCT abnormality alone. That also does not establish glaucoma. A visual field defect alone also does not establish glaucoma. Each finding must be interpreted along with the optic nerve appearance, the pressure profile of the patient's history, his family history, and change of the findings over time. And this is how we recognize a glaucomatous optic neuropathy, by bringing together the structural and the functional evidence in the correct clinical context. Glaucoma is not one single disease. It is an umbrella term for different disorders that can ultimately produce progressive glaucomatous optic neuropathy. For beginners, there are two important ways to classify glaucoma. The first classification is based on whether there is an identifiable cause. When no other ocular or systemic condition clearly explains the glaucoma, we call it primary glaucoma. And when glaucoma occurs because of an identifiable associated pathology or process, we call it secondary glaucoma. For example, secondary glaucoma may occur in association with inflammation, with trauma, with lens-related problems, pigmentary dispersion, pseudoexfoliation because of neovascularization, medication exposure, or other disorders. All these are secondary glaucomas. At this stage, you do not need to memorize each subtype. The important idea is that primary glaucoma has no identifiable associated cause and secondary glaucoma has an identifiable cause or associated process. The second classification is based on the anterior chamber angle and the mechanism involved. This gives us the broad categories of open angle glaucoma and angle closure glaucoma. Open angle glaucoma develops in an eye in which the angle remains open on gonioscopic examination. Angle closure glaucoma occurs when the angle is narrow or closed, affecting access to the trabecular meshwork and altering the mechanism of pressure elevation. If you want, you can visit our video on anatomy of the angle and also the aqueous humor dynamics. Then there are also developmental and childhood glaucomas in which abnormal development of the anterior segment or the drainage system plays an important role. So when we evaluate a patient with glaucoma, we do not stop after recognizing the optic nerve damage. We also ask, is this primary or secondary? Is the angle open or closed? Is there a developmental or other specific mechanism? And different mechanisms may lead to the same final endpoint, progressive glaucomatous optic atrophy or neuropathy. Established glaucomatous visual loss is currently not restorable in routine clinical practice. So therefore, the aim is therefore not to recover the neural tissue that has been lost in glaucoma, but our aim in glaucomatous patient is to identify that they have the disease early and understand the risk of their progression and preserve the visual function that is remaining in these patients. And this is the long-term purpose of glaucoma care. That is, you have to preserve visual function and quality of life over the patient's lifetime. Alright, now to understand how we assess the risk and how we influence the course of glaucoma, we now need to return to the intraocular pressure. Intraocular pressure is one of the most important measurements in glaucoma. It is also the major modifiable risk factors. Before we go further, let us understand what we mean when we say that an intraocular pressure is normal. When we measure the intraocular pressure in a large number of healthy people, most readings gather around an average value. Some readings are a little above the average and some are a little below it. Now, in statistics, we describe this natural spread around the average using something called a standard deviation. Traditionally, a value that lies within about 2 standard deviations on the either side of the population average is considered part of the conventional reference range. For intraocular pressure, this led to the traditional upper reference limit of about 21 millimeters of mercury. Okay? So 21 millimeters of mercury is a statistical reference point. It tells us what is uncommon in the reference population. It does not tell us that 21 is a biological dividing line between a safe optic nerve and an unsafe optic nerve. Okay, we have already seen why. Now there are 3 simple clinical situations that you need to understand. The first is ocular hypertension. Ocular hypertension means that the intraocular pressure is elevated, but there is no detectable glaucomatous optic nerve damage or no corresponding glaucomatous visual field loss. This is a risk state but not established glaucoma. The second situation is glaucoma with elevated intraocular pressure. Here, characteristic glaucomatous optic neuropathy is present, visual field loss is present, and the IOP is also elevated. The third situation is normal tension glaucoma. Here, characteristic glaucomatous optic neuropathy and corresponding functional loss are present, even though the untreated IOP measurements remain within the conventional population range. Now, briefly, we'll discuss 2 studies. One is the ocular hypertension treatment study. This helps us understand why are we calling ocular hypertension a risk state. Its participants had elevated IOP, but they did not have any glaucomatous damage at the optic nerve at baseline. And they were followed for 5 years. At 5 years, the cumulative incidence of primary open angle glaucoma was 9.5% in the observation group and 4.4% in the group which was receiving pressure lowering treatment. Okay, so this tells us two things: that elevated IOP increases the risk of developing primary open angle glaucoma, but elevated IOP does not mean that glaucoma is already present, and it does not mean that every patient will develop glaucoma over the same period. Okay. Another study is the early manifest glaucoma trial study, which studied patients who already had an early open angle glaucoma. It showed that lowering the intraocular pressure delayed progression, including in eyes with normal and elevated baseline. Together, these studies explain the role of IOP very clearly. IOP does not independently establish the diagnosis of glaucoma, but it is clinically important because it influences the risk and progression, and because it can be modified. The next question is, what do we call a patient in whom glaucoma is possible but not yet established? A glaucoma suspect is basically a patient in whom glaucoma is possible but not yet established. This may be because of the elevated IOP, or it may be because the optic nerve looks suspicious, or it may be because there's a suspicious nerve fiber layer finding, such as a possible nerve fiber layer defect. It may be because there's a suspicious visual field finding, or it may be because of several of these findings are present together. A glaucoma suspect does not necessarily have established glaucoma. The purpose of evaluating a glaucoma suspect is to establish a reliable baseline for that patient and decide whether there is a convincing evidence of glaucomatous optic atrophy or neuropathy. We need to understand the pressure, we need to understand the anterior chamber angle and likely mechanism, and we need to examine the optic nerve in this patient. Also, we need to do a structural assessment when appropriate, functional assessment with visual fields, and we need to follow up over time closely these patients to look for consistent change. This is why glaucoma diagnosis require a clinical synthesis rather than one isolated pressure reading or cup disc ratio or an OCT result or one visual field test. Thank you for watching. These are the references and have a nice day.